Okay, so today we have the great pleasure of welcoming Mirjam Kretzschmar from Utrecht University. She's a full professor and she will talk about modeling contact tracing for COVID-19. So Mirjam, feel free to start when you want.
Okay, thank you, and thanks for inviting me to give this seminar. So I will mainly talk about modeling contact tracing for COVID-19. I did this work and also other COVID-related work with this larger research group at the University Medical Center in Utrecht. So these are the, let's say, the core people who worked on various COVID projects together with me. And yeah, I also want to acknowledge the funding that I got from IMB, the Dutch research organization, and a Horizon 2020 project called CORESMA. We in Utrecht started working on COVID-related questions in March 2020, about a year ago. And we since then worked on various topics related to COVID-19.
Excuse me.
Yes?
I think we are still at the first slide. Are you?
Oh, really?
Yeah.
Oh, that's strange.
So maybe there is a problem with visualization. So maybe you should open separately the PDF. And is it a PDF? I don't know.
It's a PDF, yeah.
So yeah, we don't see any changes. Maybe you can start over. You should share the whole screen instead of sharing just.
I don't know how to do. I have a message here. It says sharing must bring your shared window to the front.
Stop to share your.
Yeah.
Yeah. Now we see. That's fine.
Okay,
don't touch anything then.
Okay, but then I can't share full screen because this is now. You know.
Can you change to the next slide, for example, just to see?
I can do it like that, maybe.
Just with the, yeah, we see it.
So, okay.
Yeah, no, it's okay. Sorry for interruption.
It's just not full screen then, but okay.
That's fine. That's fine.
Okay, so this is the research group I just mentioned, people that I worked with on various COVID-related projects, and also the funding that we received from IMB, the Dutch research organization, and the Horizon 2020 project, CORESMA. So we started working on COVID-19 related projects in March 2020, and since then worked on a number of different topics. And also some of them have been published, and we also got some media attention for various of those publications. So some topics that we worked on were, well, contact tracing, as I will talk about in more detail later, but also we looked at the impact of school-based interventions, impact of interventions in hospitals, and more recently also on vaccination strategies and in combination with lockdown fatigue and also other non-pharmaceutical interventions. So contact tracing, of course, we all know contact tracing already from before COVID times because it's an important intervention also used for many other infectious diseases. For example, in some STI, like chlamydia infection or gonorrhea, but also for Ebola infections, contact tracing has been used. And the idea is to make use of the contact network of an infected individual to find other infected persons. So you see it here in the picture. You have an infector and here an index case. This index case is somehow found because maybe the person has symptoms and gets diagnosed. And then from that moment on, one can try to find the contacts, either the ones that this person has infected, which is then called forward tracing, or one can also try to go back and find the person who infected that index case, which is then backward tracing. And one can either just do this for one step, or if one finds in the contact tracing new infected individuals, then one can do this for multiple steps and also look into contacts of that infected contact and so on. And for all these different situations, mathematical modeling approaches have been developed already in the past. I recently also wrote a review paper on those modeling approaches and new challenges together with Johannes Müller from Munich. So if you're interested in that, I can recommend it to you. So what's now the specific question that we have if we think about contact tracing for COVID-19? I will mainly now present to you some work that we published in 2 papers. This one in Frontiers in Physics, which was actually published later than this one in the Lancet Public Health, although this one actually was work that we did earlier. But now, as it works sometimes with publications, the earlier work takes longer to get published than the later work. But this one, let's say the first one is more the basics of the model, and the second one, I would say more an application for the more epidemiology audience. So the questions that we wanted to look at were, in general, can contact tracing actually be used to control the epidemic? And if yes, what are the conditions for that? How fast does contact tracing have to be to control the epidemic? And how can we compare conventional contact tracing and digital app-based contact tracing in their effectiveness? And to do this, we used a stochastic branching process model. It's relatively simple, so that we can explicitly calculate the basic reproduction number and effective reproduction numbers, and also doubling time and exponential growth rates. And that's the big advantage of this model. On the other hand, it has limitations. For example, we only look at forward tracing and not at backward tracing, and also only one-step tracing. So in that sense, it's quite simple. So to see what kind of parameters we have to take into account, this is a kind of schematic view of contact tracing for COVID-19. So here we have an index case, and then this index case first has a latent period in which he or she is not infectious yet. Then infectiousness develops, and the person can infect others. And then at some point, and that's denoted here by D, the person gets diagnosed, so develops symptoms, goes to the doctor, gets diagnosed, and then from this point on, one looks back a certain time period, which I call here tracing window, and all contacts that have been done during this time period are then traced, and possibly, if they're infected, then isolated. So for example, for this index case, the first 2 secondary cases that this person produced aren't found because they were already before this tracing window. But this case here was found, and then actually at the moment T, this person was traced and then isolated himself. And so other contacts that he might have infected, if not traced, now have been prevented. So you see already here that it depends very much on the interaction or the relationship between those different time periods that play a role, like latent period, infectious period, tracing window, and so on, how effective this contact tracing is going to be. The model that we used is defined in time steps of 1 day, and I always denote by tau the days since infection or since start of the infectious period. And so the model contains various parameters and assumptions. One is about contacts. So we distinguish between close contacts of a person and casual contacts. Close contacts that could be, for example, household contacts or other people that you see very regularly. And we assumed here that the number of these per day have a Poisson distribution with a certain mean mu1, while casual contacts are negative binomially distributed with a mean mu2. And to parameterize these distributions, we used data like polymorph data from contact surveys or other, let's say, similar contact data. So for example, here you see in this graph here, contact data that was collected in the Netherlands before COVID-19. So that's the baseline. That's basically the polymorph data set. And then here at 2 time points during the pandemic. So in April 2020, when we had a very hard lockdown, and in June 2020, that was after the first lockdown. And so using this kind of data for estimating these mean numbers of contacts, we can also look at the impact of social distancing on those distributions. And social distancing in the model is described by reduction factors, RH and RC. So RH stands for household and RC for casual. So these reduction factors are applied to these means of the distributions to parameterize social distancing scenarios. Then to describe the infection and transmission process, we assumed that the latent period lasts between 1 and 3 days with a certain probability of moving from latent to infectious per day. And the infectious period then lasts 10 days. And transmission probability, we assume to be proportional to infectivity. And this infectivity, we actually used data that was published in papers by Hay et al. And Ashcroft et al., who estimated this infectivity distribution and also the incubation period distribution. And we calibrated this so that the basic reproduction number had a specified value, and mostly we used 2.5 as the baseline value for the basic reproduction number. Furthermore, we also assumed that in casual contacts, the transmissibility is reduced by a factor 0.25. This is a bit arbitrary because we don't have any data about that, but we simply wanted to represent here that the transmission probability is higher for closer contacts than for casual contacts. And then if we put all these assumptions into our model, we come up with these kind of distributions that are then used in our simulations. So distribution for the transmission probability per day of the infectious period, probability of developing symptoms per day since infection, the number of contacts per day, and the percent transmission taking place per day since infection. And if you look at this plot D here, you see that if the incubation period is about 5 days, which is estimated in the data that we used, about 40 to 50% of all onward transmission has actually already taken place before symptom onset. And this is also something that has been observed with COVID-19 and makes the control of COVID-19 so difficult. Then we also need to describe diagnosis, isolation, and contact tracing in the system. And the assumptions we used here were that first, cumulative probability of developing symptoms overall is maybe less than 1. So this reflects that actually infection may remain asymptomatic completely. And usually we assume that in 80% of all infections, there is symptoms at some point during the infectious period, and in 20%, they remain completely asymptomatic. And then if there is symptom onset, so at some on one day during the infectious period, the symptoms occur, and then the index may be diagnosed and isolated, but there may be a testing delay between symptom onset and actual isolation, which we denote by D1. And then also when this index case is diagnosed, tracing starts, and after another delay D2, contacts are found, and a fraction C of those, and that's called tracing coverage, are then isolated, and we assume that in isolation, cases do not transmit any further, so isolation is perfect. And the main idea for the analysis and derivation of the reproduction numbers is that for every day tau since infection of the index case, probability of diagnosis can be calculated based on all these assumptions, and also the associated reduction in onward transmission by isolating the contacts. Because for every contact we know, let's say on which day of the infectious period the person has been infected. And so if that person is isolated some time interval later, we can calculate how much of that person's onward transmission potential is actually prevented by isolating him or her. So the model basically consists of all kinds of probability distributions, which I only shortly mention here. So there is a probability pi of tau to move from the latent to the infectious state. And DE is the duration of the, or the maximum duration of the latent period. And then there is a probability of transmission upon contact, PT, during the infectious period. There is a probability PS of symptom onset per day of the infectious period. And there is a probability PD of being diagnosed per day of the infectious period. And finally, there's a probability of being traced by contact tracing for the contact of the index case. And this is also here written as depending on the day tau of the day tau of the infectious period of the index case. So if we write down the probability for this contact to be traced, it depends on the coverage of the contact tracing. It depends on a probability that the index is not yet diagnosed up to a certain day tau, and the probability of diagnosis on day tau. So combining these and adding up over all days of the infectious period leads to this expression for the probability of a contact to be traced. Now, using this, we can calculate reproduction numbers. So the basic reproduction number without intervention is given by this expression here, where you see here occurring the mean numbers of contacts for close and casual contacts per day of the infectious period, and transmission probabilities. And here this Q is the reduction factor by which non-household contacts are less transmissible than household contacts. And using this, we can also calculate what is the proportion of onward transmission generated up to a day tau of the infectious period by simply adding up all these, let's say, expected secondary contacts up to day tau of the infectious period. Now, to show you a bit how this works in a graph, this is the contact tracing process, and we have several time points here that are relevant. So here T1 is the time of becoming infectious. T2 is symptom onset. T3 is the time when the index case gets a positive test result and gets isolated. And T4 is the time when the infected contacts get traced and isolated. And you see also that here again, this tracing window. So that's how far we go back to find these contacts. And what I try to show you here with these kind of reddish curves is the onward transmission potential of those secondary contacts. So if a contact is isolated here at time T4, a certain part of his infectiousness has already passed, and he might have already transmitted to others in that time period. And what we can still prevent by isolating that person is everything that comes after time T4. So for every of these contacts, the amount of infectivity that can be prevented depends on when exactly that contact has been infected and when that contact is traced. So everything that is on the right-hand side of this time point T4 can be prevented. And yeah, that can again be calculated based on the probabilities that I introduced earlier. And it is simply a combination of these infection probabilities, and here you see this this quantity rho, which calculates the transmission potential up to a certain day at a day sigma minus I, and sigma is the day since infection for the contact person, and I is the day at which the index person is actually identified and diagnosed. Yeah, it's getting more involved then, because from this we can now also calculate what is the probability of preventing onward transmission of contact persons. And in a sense, it's a combination of the previous quantities. And I call it here psi of t, because this is the quantity that then enters into the effective contact rate. So that you see down here, that's the effective contact, the effective reproduction number, and it consists again of a combination of different terms. Here, a first term that is describes the reproduction within the close contacts, so mean contact rate, transmission probability, and then here a factor, a reduction factor that depends on how many of the onward, how many of the contacts can be found and how much of their onward transmission potential is prevented. And similarly for the casual contacts. So this psi, in a sense, is a weighting factor that weights prevented or isolated contacts according to how much of their onward infectivity can be prevented by isolating them at a certain time during their infectious period. And now, because this psi here contains the in fact, the contact tracing coverage, C, we can actually ask how high does this coverage have to be to get this effective reproduction number below 1. So if we calculate the root of this equation RE equal 1 and solve for C, then this is what we call the critical contact tracing coverage. And that's what we then plotted, for example, here. So here what we varied on the x-axis is the fraction of symptomatic individuals. So in the baseline, we assume that 80% of infected persons develop symptoms at some point. But if you make this lower or higher, you can look at how much better is contact tracing going to be. And we also varied here the basic reproduction number. But if we look, for example, at the, let's say, a baseline value of 2.5, that's this middle purple line here, we see that if the fraction symptomatic drops is below 90%, then we need contact tracing. And let's say the lower the fraction of symptomatic persons is, the more traced contacts have to be found and isolated to reduce the effective reproduction to below 1. And the assumption that we have here is always that all household contacts can actually be traced and isolated. And so the critical tracing coverage here relates to the non-household contacts. Yeah, but of course this can be varied in the model, but because there are very many parameters that can be varied, we had to make choices in what to actually keep constant. And our, let's say, strategy here was to assume quite optimistic parameter values for the contact tracing, and then look at what happens if one of the factors is, let's say, less optimal than in the fully optimistic baseline scenario. Yes, then here we looked at the impact of social distancing. So again, we looked at reduction of non-household contacts, assuming that household contacts are much harder to reduce because you live together in one household. So these contacts are basically kept up. But if non-household contacts are reduced with a certain fraction of a certain percentage, then the more reduction in contacts you have, the easier it will be to actually reduce with contact tracing the effective reproduction number to below 1. So that's what you see in these two plots here. One is for an assumption that 80% of all symptomatic people get tested, and one is for 60% testing of symptomatic people. Still quite optimistic, of course. But, and we assume that all household contacts get traced and quarantined. And then if we need, let's say, if 100% of all household contacts are quarantined, then, and we still need more contact tracing to reduce the RE, then also the non-household contacts get traced and quarantined. So that's what you see in these two colors here. So in the brownish area, it is sufficient to trace and isolate household contacts, and in the purple area, in addition to all household contacts, also non-household contacts have to be traced to get the RE below 1. And in the white area, it's not possible, even with the most optimal contact tracing, to get the RE below 1. So you see that if there's not enough reduction of contacts, then contact tracing alone can't really control the epidemic. Now, exponential growth rates and doubling times can also be calculated from these distributions. Again, you see here that we have the contact rates and transmission probabilities here, and the growth rate R is here in the exponent of this exponential, and the root of this equation. So if we solve for R, we get the exponential growth rate, and the doubling time can then be calculated from the exponential growth rate. And we looked then at how growth rates and doubling times depend on testing delays. So that's the delay between symptom onset and diagnosis and isolation of an index case, and also on tracing coverages. So the coverage of, so how many % of all infected contacts are found and isolated. And you see that with increasing testing delays, exponential growth rates can't be kept below 0. Actually, the testing delay has to be very short to keep this exponential growth rate below 0. And also tracing coverage has to be quite high to keep it below 0. And here you see the corresponding doubling times that go, of course, quite high when you are near an exponential growth rate of 0, but when you're away from that, they can remain quite short.
Excuse me, Mirjam, I think
yes?
we should stop here because we want some time for question and we want some time for the next speaker.
Okay.
So maybe you go to the conclusion you want to give.
Yes.
Rapidly, but.
Okay, then I leave this comparison of the strategies. Okay, so basically my conclusions are that in a population with social distancing, contact tracing can keep the effective reproduction number below 1. And we see that reducing the testing delays, or the time between symptom onset and a positive test result, is the most important factor for that. Reducing tracing delay can enhance contact tracing also. And if contact tracing is fast, it can prevent quite a large proportion of onward transmissions. Because we think that digital contact tracing actually has the potential to be much faster, it could help, but of course it is limited by the coverage of the app use. And yeah, this is a picture of Utrecht, and thanks for your attention.
Okay, thank you, Mirjam, for a very interesting talk, very clear. Now, if you have a question, you can raise hand, for instance.
So can I start, maybe?
Yeah, okay, you can start.
I have two questions, actually. At the beginning, you mentioned that you were able to estimate the time of exposure, and you had some distribution depending on the age of infection. I was wondering how you get that, because is that estimated from the cumulative number of reported cases, or what? How do you estimate that?
Let me go to the beginning.
And the second thing is, what is your model for contact tracing? Because you never show any model so far.
Okay,
so no, earlier you had some distribution. Yeah.
I think he starts on that, actually. It's 1 or 2 slides after.
Yeah, after?
Yeah, after.
Oh yeah, those ones. Yeah, yeah.
Here?
Those,
This one?
yeah, yeah, yeah.
So which distribution do you mean now?
But you mentioned the let's see, probability. For example, the first one. How do you estimate the first one?
Okay,
Is
so
that this is based on some mathematical model, right?
Well, it is. Yes, it's a gamma distribution, and we fitted it to existing data. So it's basically fitted to the data that was published here by. We use this data by Ashcroft.
You fix a gamma distribution for this distribution, and then yes, you fit that to the cumulative number of reported cases, or what?
No, this is we didn't use any information on reported cases, because we actually, in what I presented now, I just looked at effective reproduction numbers. So we didn't actually look at case numbers here. So this is just fitted to information on infectivity, that's from the data, and incubation period, that's also from the data.
Which data?
The data that is in these papers. So basically, so this is the data that comes from Outbreaks. Basically these two papers, Hay et al. And Ashcroft et al., they used data to...
No, but which kind of data is that? I mean, is that age-dependent, infection age-dependent
yes, data from, well, actually, let's say data where it was recorded when an index case had been infected and which secondary infections that case produced. So you had information on time between...
oh yeah, based on interview or something like that?
Yeah, and yeah, basically, how do you call it? Outbreak investigation, where you ask people when did you meet that person, and when did you first have symptoms, when did you probably get infected by that person. Of course, it's never, you can never say that with certainty, but you can, let's say, you have then information on when did people have their first symptoms, and you can fit some kind of transmission model to that data to extract these kind of distributions.
And then, sorry, but my second question is about the model for contact tracing. What is your model? Because you mentioned some generality about contact tracing. You never mentioned a real model, I mean, about how you model the contact tracing. Is it?
Well, basically, the contact tracing is modeled in a sense that the model describes the probability of all those events that happen. So it describes the probability of a person moving from the latent state to the infectious state, and the probability per day or since age of infection to transmit to others.
It is always measured from you look at the number of cases you got, and then you go back, no? Is that a model like that? So where do you start from?
No, I start from, let's say, I start from the infected index case, and I compute the probability per day of, or per day since infection, that person produces secondary cases, and also that that person is diagnosed at some point, and what is then the probability for those cases, for those secondary cases, to be found by contact tracing and isolated. So in a sense,
sorry, you turn around.
Yes, I turn around.
Because the point is, you get some guys without contact tracing, say, and then you add the contact tracing, right? No,
Um,
that's no.
Yeah, in a sense, I don't know exactly what you mean now. Of course, yeah, if you,
Yeah.
you can look at the same process
So,
without contact
okay.
tracing, and then you get simply then it's simply a branching process for the infections that happen. And actually, I mean, the model here, I only talked about this effective reproduction number, but the model can also is simply a simulation, let's say a time-dependent simulation of per day.
Matter if this is a simulation or not. I mean, it's just a probabilistic model because that can be written as an ODE in the end or something like that.
As what?
As an ODE or PD, whatever.
Well, not as an ODE, but yeah, it's a kind of branching process.
Yeah.
Yeah.
Yeah. Okay.
Did that answer your question, or?
Not really, but that's fine. I can
Okay,
live
then
with that.
I don't really understand what the question is then, but yeah, maybe we can discuss it some other time.
Yeah, any other question? So maybe it's time to switch to our next speaker. Thank you again, Mirjam, for a very nice talk.
Thank you.
And we'll switch to Amber. Let me just change recording.
Oh yeah.